My name's MikeBaer. I'm a physical therapist with Rebound. I've been with Rebound for about 10 years now. And my talk this morning is on current concepts in spine rehabilitation. And what I usually like to do in these situations is just get a sense of who my audience is. So I realize you're all athletic trainers. Do we have any physical therapists? I know we have at least one. Any other? Oh, great. And how many of you spend at least 50% of your treatment time treating spines? Great. 25%? Great. Okay. So also, if you have any questions at any time, don't hesitate to interrupt me while I'm doing this. So, as I mentioned, today's talk is current concepts in spine rehabilitation. No disclosures. Okay. First thing I thought is talk a little bit about spine rehab history. I've been a PT for over 25 years now, and when I started, we were trained in what amounted to a biomechanical model. And what that meant was we had a very good understanding of the theoretical ideas of how the spine moved, and that was where the emphasis was. It was very bone and joint oriented, a little less focused on the muscular aspect of it. And we focused a lot on specific segmental dysfunctions, meaning our ability to actually palpate and feel what was going on segmentally in the spine. We relied a lot on palpation. I can't tell you how many courses I went to where we're trying to feel the actual very specific movements in the spine, typically in an unloaded situation. And we assumed manual therapy, which is what this biomechanical model supported, was very specific, and that our treatments were very specific. Well, oops, hang on. The reality. Well, what we've discovered probably in the last 10 to 15 years is that this biomechanical model, this very specific model of movement, didn't really take enough into consideration the nervous system. And the nervous system's impact on how we move, how we stabilize, essentially how we function. We also found that the palpation of segmental levels and determining the dysfunction at those levels was incredibly inaccurate. And that manual therapy, despite all of its emphasis in the education environment, was not very specific. So what this led to is today, and where I found that a lot of really good, intelligent people that have in the past taken a manual therapy approach have come together and really created a much more eclectic approach in terms of rehab of the spine. We've recognized the real limitations of passive interventions, which include manual therapy, manipulation, all the modalities that we're famous for. And we're using much greater utilization of movement and exercise and understanding much better the neurology, how the nervous system works in movement and exercise. Greater utilization of progressive loading, which I think is a real important thing, and something that has not been emphasized in the physical therapy world, and utilization of pain science concepts. So before I get started, I'd like a few definitions. First of all, how many of you are FMS or functional movement screen, SFMA? Okay, great. So a few definitions just that I use throughout the rest of this talk, just to be clear. Talking about directional preference, and this comes from McKenzie, and their use of repeated movements to determine the direction of motion of any joint that improves the range of motion or centralizes neurologic symptoms. So basically what it means is, by directional preference, what direction does your spine patient move that either decreases their nerve symptoms or improves their range of motion. Also, I would say decreases their pain. And then the other definition is regional interdependence, and seemingly unrelated impairments proximal or distal to the primary dysfunction that may contribute to the symptoms that your patients are having. So this is what it comes down to. Evaluate with repeated movements and with a functional movement screen, okay? Reset are your treatments that are trying to normalize motion in a way that they can progress to actual stability or stabilization. And by stabilization, I don't necessarily mean core stability and that type of thing. What it really means is building in resilience to their spine so that they can get back to either normal ADLs, normal work, or normal sports activities. So the repeated movements, which we mentioned previously, which are typically done to determine the directional preference. And in its simplest form, it's having people doing repeated movements into flexion and extension. And it's typically done in different positions. You're usually, either this is done in standing, it's done in, it also can be done in quadruped, and also laying down. And the goal with this is to determine that directional preference, that preference that they want to move that will either centralize their nerve symptoms or decrease their back pain or improve their motion. How it determines load tolerance, and load tolerance really is how much is their spine in their current condition willing to accept, and we do that by changing positions when we're looking at directional preference. So you'll do it, you'll have them prone, you'll have them laying on their back, you'll have them in quadruped, you'll have them in standing. So different positions where they're loading the spine in differently. And then the other thing that repeated movements help us to, because we're changing those positions, it helps us determine what is the best starting position for them to rehab. If you have somebody who's doing repeated movements in standing and their symptoms do not centralize or they don't get any better, clearly they aren't going to do any rehabilitation in standing. So you're going to move them into different positions where they're loading the spine, there's less of a load on their spine. So this is an example of the type of repeated movements, and this is sort of classic McKenzie, where you'll have them do repeated movements in standing, and again, you're looking for centralization of nerve symptoms, you're looking for decrease in their pain with repeated motion, and then you're also looking for improvements in their range of motion. We show this in a couple of different positions that again accentuates the different loading in their spine. So again, as I mentioned previously, if you're finding that someone's symptoms do not change significantly in standing, we move them into supine and evaluate in that position, just to determine again, what's their load tolerance? Where are we gonna start where the rehab position and what's gonna be most optimal in terms of moving them forward. This is repeated movements, like I said, in its simplest form, in flexion and extension, but in the reality of it, when it's done well, you will take them in their different positions of loading and load essentially try to load the spine in 3 different planes. And then the functional movement screen. This is the second aspect of the evaluation, and again, selected functional movement assessment, SFMA, functional movement screen. There are many others that can be used, and they all effectively do the same thing. And what we're trying to do is determine regional interdependence. So again, if you're talking about somebody with back pain, the classic example that we will see is hip stiffness, and typically when you're using a functional movement screen, in this particular situation, the thing that we're looking for is stiffness. Stiffness that is typically not painful. It may be represented as asymmetry of movement through the hips and through the pelvis. And the reason why those are important is oftentimes those things can be secondary things that impact patient's spinal condition. So again, regional interdependence, we're looking for stiffness. Fortunately, in our world, one of the things that we can break through the quickest, the easiest thing to treat is this stiffness. The kind of classic example is thoracic spine stiffness and its impact on the lumbar spine. We'll see this all the time. A lot of this is postural in nature. And what happens is people are very stiff in their thoracic spine, and to accommodate for that, you'll get an accentuated lumbar lordosis, which over time, and especially in athletes, can lead to problems with low back pain. Additionally, hip stiffness or asymmetrical hip movement. If patients lack hip extension, it just sort of silently sits there, but it creates an increased lordosis in the lumbar spine. As we move on to the second aspect of the overall treatment, the reset. Reset is just all the treatments that you know to use. These are manual therapy, manipulation. These are the passive modalities that are currently popular, such as dry needling and laser. They're taping. And these are the passive things. I don't spend a huge amount of time on these because I think the research has really shown that they have benefit to facilitate motion within a treatment session, but there's very little carryover. And so the point of this style of treatment is to get your patients moving better within the clinic, within your treatment, within that period of time that you're treating them, and facilitate that sort of transition into the stabilization. And so 3 phases of rehab that I like to focus on. Phase 1 focuses on isometrics, and these are basic, what I would call abdominal wall isometrics, okay? And the reason why we start there is because what we want to do is teach people, again, proper bracing techniques. And the other thing that I don't mention here that I think that's important, it's important is to be able to emphasize these bracing techniques with good abdominal type breathing. That focus, and the reason why I think it's fundamentally important is that it allows people to teach themselves or to learn how to move in a way, in a protective manner, so that they're protecting their spine while they're doing normal activities of daily living. Phase 2 focuses, we transition to functional mobility and the importance of being able to brace adequately while you're doing functional mobility, which to me is squatting, it's lunging, it's getting in and out of bed in a way that doesn't tweak their back, okay? In phase 3, we progress into increased loading, and I think this is something in the past that physical therapists have not done well. I think that we have often sent the message to our patients that your spine is very delicate and you have to be very careful with how you load the spine, and I think that's been a mistake. I think these days we're now much more we're thinking much more, how do we progressively load these spines to build this resiliency? And then phase 4, which I'm not really going to spend a lot of time on because Steve's going to talk about this today, is return to sports and work hardening. So isometrics are just very simple. This ability to contract the abdominal wall, and you'll notice I'm not spending a lot of time focusing on isolating transverse abdominis and that type of thing, which I think in limited respect has been effective in the past, but I also think it's another example of how we sort of broke things down too far and it was not very functional. What we're seeing here is the use of very simple, reflexively induced isometrics in 3 different loading positions. And I think that's one of the important things, is to look at where can we load people, even in this basic level of using isometrics, okay? And again, like I said, what I like to teach is this good abdominal breathing over the top of it, and it gives patients a much better sense of control over their condition, especially during activities of daily living. Phase 2 is functional patterns, again in 3 different types of loading. And you can see here there are many different patterns you can use. These are just examples of essentially a squat that we're doing in 3 different degrees of loading. This is probably where I spend most of the time, is just getting people moving. And again, if you're familiar with FMS and SFMA, there are many different ways to facilitate these patterns and give people adequate stability so they can progress. And then loading, okay? And this, again, as you know, can come in many different forms. And I think the kettlebell people have taught us that we can really load people up as long as it's done in a smart, progressive way, in ways that teaches them that it really is okay to lift, it's okay to bend, and that your spine is a pretty resilient structure. Okay, so eval, reset, stabilize. That's what I find is very simply is where things are at in the progressive way of spinal rehab. All right. Does anybody have any questions with regard to that? Very good. Yes?
Are you using this same approach for, let's say, all three case studies that were presented earlier? So is this like when they go to rehab, this is the approach you're taking with it's just back pain, if it's a disc herniation for radiography, or?
You know, I think there are, yes, effectively yes, and that's what I think what truly makes it effective, is that, and remember that when we're doing repeated movements in directional preference, that's where it all starts, and that's where you get the idea of the direction you need to go with it, okay? You know, I see what you're saying with this, and you know, the thing about directional preference and those movements, they get pretty subtle in terms of how you, the examples I showed were really just single plane movements, but they really take them into triplane movements to really determine what is the true directional preference. And that, you know, we're just getting feedback from the patient in terms of, okay, what do they need to move this in the right direction to get into that the more rehab world where you're building that spinal resiliency. And you had a nice question with regard to the pain science piece and things like that. That's a really interesting, and that's really is our world. I think that's one of the components I didn't really emphasize a lot here, but it certainly is a big part of it. As you all know, whether you're totally aware of it or not, that you deal with this every day in patients that catastrophize with regard to back pain. And you know, I think education and knowledge is one of the keys that you know, we have to get these, especially these young athletes, through fear avoidance and really good understanding of their pain. Like Dr. Regal mentioned, 85% of these kids will just get better spontaneously. And if they truly understand that, and I can't tell you how often I've had patients come in and they will refer to an MRI from 6 months ago that says, you know, I have a moderate bulging disc. Well, no, you don't. Okay, you don't have that anymore. You know, if you're here and you're walking around, yet it's interesting to see because of their understanding of their condition, how their pain is perpetuated, how their inability to move is perpetuated. And you know, not only is the spine incredibly resilient structure, but the human body is amazingly adaptive. And that's the thing that I think we need to see. And that's what we need to educate our patients more about. Yeah?
Follow up there, looking at that based upon observation, Stuart McGill has always said that the pelvis is the platform for the spine.
Yeah.
So looking at patients who come in with low back pain, you have to get stiffness, but how many are not able to control their pelvis and they're in an anterior tilt bit?
Yeah, you know, I would totally agree. You know, and I think the primary thing I am looking for in when I say stiffness, I'm also looking for stability and motor control. Okay, and that's a big piece of it. Although, you know, when you think about it, you really do hit that in the stability piece as well. I mean, when you're taking people through functional patterns and functional motion, you know, you're dealing with the spinal component of it, but you're also dealing with stability and motor control through the pelvis as well. And I would look at that. I mean, that's kind of the way I look at that as well. Right? And you know, it's interesting. We separate these things out: stiffness, strength, stability, motor control. But it's all integrated together. And I think, in many regards, one of the mistakes we make is I say something like, I'm looking for stiffness. Well, stiffness is a combination of a lot of different things, and it all interplays together. And it's one of the things that I think we, as treating clinicians, we need to do is view it a little bit more that way, a little bit more integrated approach. Great. Thank you.